The views, opinions, and information expressed in this podcast are those of the individual hosts and guests and do not reflect the official policies or positions of the organizations they represent, work for, or are affiliated with. This podcast is for informational purposes only and is not intended as medical advice. Please consult a healthcare professional for any medical questions or concerns.
So today we have Darla Cathcart. Currently serves as president of the Academy of Pelvic Health of the American Physical Therapy Association. She is a highly accomplished physical therapist specializing in women's health, holding advanced degrees from Louisiana State, Duke, and the University of Arkansas Medical Sciences. Her career includes clinical practice, education, and research with a focus on pelvic health, pregnancy, postpartum care, and notably her PhD work was on non-invasive brain stimulation for vaginismus. She has developed key programs and certification like CAP-OB, authored numerous publications, and now teaches as a faculty member at Graceland University. Personally, she is a mother of twin boys, a lifelong runner, and enjoys dark chocolate, craft beer, and her 4 dogs. That's a full house.
It's a lot of dogs.
Awesome. Do you want to kick us off?
Yeah. Well, first of all, thanks so much for coming out. You mentioned you flew in from Arkansas, so really appreciate it.
Thanks for having me.
Yeah, no, we're very excited. I think maybe just taking it back to the start, I think, you know, you were one of the first people ever to do a residency in pelvic health back at Duke. What got you in the space, and tell us a little bit more about it?
Yeah. So I went to physical therapy school. I started in 2000, and pelvic health was not completely new, women's health, because it really started as a women's like OB-GYN component, and it's kind of grown into this, you know, across genders, across ages, pelvic health component where there's a lot of overlap between women's health and pelvic health. But when I went to school, nobody really knew what it was. But my sister had some pelvic pain and she got referred to a pelvic therapist, and I had just applied to PT school, and my mom called me and was like, "Why is your sister being referred to physical therapy for her pelvic pain?" And my response was, "I don't know, but I'm intrigued." And it was just sort of this calling right off the bat. So I went into school knowing that's what I wanted to do, which was kind of weird in the 2000s or early 2000s. I think there are a lot of physical therapists that go to school now that they've heard about this, they know about it. You see it all over social media. You know, it's so common and it's growing so rapidly. But that was it was just kind of this draw of, oh, there's this, you know, area of physical therapy that is addressing a need that's very underserved. And it's just so necessary. So it was just kind of this draw, this passion. So I was that weird kid in PT school that, any project, I made it about pelvic health somehow. So it might be a neuro project. I'm like, let's talk about MS in the bladder. So that was my draw, my start.
You know, one of the things I'm so curious about is that you go to some places, pockets in the country, and they'll say, you know, as part of prepartum care, postpartum care, like you really need to do pelvic therapy, pelvic floor therapy. And why isn't it standardized at this point? And should it be standardized? Or is it, you know, unique for specific kinds of cases that you would recommend?
Yeah. So, you know, I think the pockets where you see it being more prevalent are probably areas where there's more population density. There's been more opportunity for mentoring of physical therapists in that area, more opportunity to educate the community, to educate care providers about this being a thing, kind of that development that, you know, takes decades of time to come through. And so then as you know, when you look at pelvic PT, women's health PT, and kind of how it spread, you know, it started in the Boston area. So Elizabeth Noble, who came from Australia. You know, she was kind of the founder of women's health PT in the 1970s, and just started with her and a couple of PTs that she taught how to do this. And so kind of spread from the East Coast, and then you know how things go. Then it was West Coast, and now the rest of the country is catching up. And so I think the bigger cities, there's just more opportunity to have pockets of therapists where there's that mentoring, that education. Then you look at, you know, smaller towns or more rural areas, less populated areas. Well, now you may have a physical therapist who says, I really want to do pelvic health in my community. So they, they take a job or their employer says, yeah, we'll help you get that started. But then there's just not good support in place. So they'll send them to one course or two courses and say, okay, start this program. And they're not really getting that good mentoring. They're not getting that more advanced education they need. So maybe they're not as successful or they feel a lot of the challenges. And so I think a lot of those, in a lot of those situations, they just kind of end up, leaving to go to one of those cities where they can get mentoring, or they quit doing it because they're not feeling supported or they feel like they're not getting good outcomes. So I think it's really just kind of a matter of, we need more resources in place for the development of these pelvic health therapists.
What are the benefits of doing pelvic floor therapy before giving birth? And then, obviously birth is one of the most traumatic events for your pelvic floor.
Yes.
And so what are the benefits after? Are some things irreparable, or is really pelvic floor therapy the way to really rehabilitate?
Yeah, I would say that pelvic therapy is definitely one of the most valuable things for rehabilitating the pelvic floor. So there are certain birth injuries that, would require more. So we know that sometimes you can have, muscles that maybe have a significant degree of tearing, and pelvic PT is only going to do so much. But for the most part, doing therapy prior to, you're increasing your motor control of the pelvic floor muscles. So now you have more control during labor and birth. So if you're trying to, bear down and push the baby out, maybe you're not fighting it so much. And the research has kind of shown that if someone does some pelvic floor kind of prehab, if you do some pelvic floor muscle training prior to birth, that those muscles they're under better control. They heal faster in the postpartum. Labor and birth tends to be a smoother process. You have less postpartum incontinence, so all of those outcomes are better sexual health return. So all of those things end up being a whole lot better in the postpartum if you do some of that training going into labor and birth.
So, historically, women have been an understudied population, right? They weren't even required to be included in scientific studies, I think, for a number of years.
Oh, yeah.
And so there's a lot of catching up to do in terms of women's health. How do you stay sharp on the most recent advancements in, the world of pelvic therapy, and where are those advancements going?
I'm going to have to think about that one for a second.
That's okay.
I hadn't thought about that question. Okay, say that again.
In terms of, there's probably a ton of advancements going on in the world of pelvic floor therapy.
Yeah.
So, how do you stay up to date with all of that?
Yeah.
Do you have communities that talk about it? Do you read papers, conferences?
I'm following you now. Okay, all right. Okay, I gotcha.
Yeah.
I was like, what direction is she going with this? Okay. So as far as staying up to date, one way that just from a personal perspective, one way that I stay up to date, I've been involved in developing some of the course content for some educational companies on peripartum health and pelvic health. And so when you're developing coursework, you're getting into the research. So you're reading the journal articles, you're staying up to date on what's out there. So that's been the way for me personally, is through my work in course content development. But certainly there are communities out in social media that, they do exactly what you said. So they do journal clubs, or they share information with each other. They have these conversations. I think those are the main ways at this point, is either getting into the research that's out there and not reading just the physical therapy research, but also getting into, what are the Urogyne journals saying? What are the OB-GYN journals saying? So really looking at a kind of across disciplines on the research and what's out there.
Got it.
So one question I have is for folks listening to this podcast, specifically practice owners, right, that may want to get more educated on pelvic health or may want to offer it as part of their services. Yeah. How do they get started?
Yeah, that's a great question. So do you mean like the owner starting?
Exactly, right?
Like bringing pelvic therapy into their clinic?
Exactly, yeah.
Yes. Okay. So one of my biggest pieces of advice is, because this is what I've seen happen multiple times, is you'll have someone who owns, an outpatient orthopedic clinic, and they say, oh, we should have pelvic therapy because this is cool and popular. It's the hot thing to do right now. And so they'll either convince one of their therapists to, hey, let's send you to a course, or they'll hire somebody specifically for that. If you are having to convince someone to go to these courses, you might get a great start. This might be somebody that goes to the course and is like, oh, I didn't know I love this. But oftentimes you get somebody that goes to the course, they're nervous, they're anxious, they're not excited about it. They're probably not going to perform as well in this area as somebody that is really gung-ho about it. So that's one thing to think about is maybe not twisting someone's arm to go into pelvic health.
Sure.
If you're hiring someone to come in who's really excited about it, then a couple of things to consider is for there to be good quality standard of care. And there's not defined standards of care that I've seen written down, but I would say standard of care in general is that you are seeing patients one-on-one. Patients are staying with the same therapist for their episode of care. They're not bouncing from therapist to therapist. You don't have your therapist trying to see a pelvic health patient and then run out to the gym and work with a patient with a knee problem or something like that, and then pop back in the room. Like, they really need to be able to be dedicated with those patients. And so just realizing that it's going to be different as far as your ability to accrue units and productivity with those therapists. So that's something you really need to be mindful of, is how do you build that into your practice? Because to do really good work, your therapists are going to need support for that. The second thing is really supporting that therapist in their continuing education and mentoring. And if they can hire a professional mentor, so find a pelvic health therapist that mentors and just hire that person to mentor that therapist for a year, 2 years, to be that support person in place. Because if this is the therapist that's starting your program, they need support to do that, support that person so that they can really grow that program and do it well. And then as you hire in more therapists, then that person can start to turn into the mentor and begin to grow that piece.
Yeah. The reason I ask is we talk to a lot of owners of practices, and they're always looking to expand their services. But they want to do it in the right way as well, right?
Absolutely.
And that's why I think some of that advice goes a long way, because half doing it is probably not good enough, right?
Exactly.
And then you lose the interest, and then you don't get the additional, health benefit and the additional financial stream as well.
Exactly.
Right. And so, I think it's an interesting point.
Curious, you're obviously on the cutting edge of a lot of this field, but even you are probably limited by the infrastructure that exists today and technology that exists today. If you were to think about what does the ideal patient experience look like for someone coming into your practice, end to end, what would that look like? Because right now, it feels very episodic. And I would imagine you want to deliver this care longitudinally, right? Or is that, or do you prefer episodic care? Is pelvic floor therapy one of the places where you would, prefer to kind of do targeted treatments?
So, tell me what you mean by episodic. Let me make sure I'm understanding.
Like just, people come in for like 3 visits and you're good to go.
Oh, I gotcha. Okay. As opposed to you're coming in and doing almost like conversion to wellness.
The same way you would go for a physical, for really the rest of your life, not just around when you have a baby or after you, the month after you have a baby, but,
I'm going to answer your question from a couple of different angles. So one is when I think about when I hear the word experience, I think about from the time that the patient gets that first phone call to schedule their appointment, or they call to schedule an appointment, or they say, hey, a friend told me I should go to pelvic PT, or we call them and say, hey, your doctor referred you. We're calling to get you scheduled. So I just think about, first of all, when you're being called to make that appointment, or you're calling to make that appointment, you're dealing with such intimate issues for so many patients. When you're dealing with bowel, bladder, pelvic pain, sexual health issues. It's intimate, it's scary. A lot of patients think, I'm the only one that has this problem in the world, right? And so they feel very isolated, very alone. And so having good trained staff that knows how to have that conversation with the patient, that can be really reassuring. So training them with some good scripts, ways to say things, way to assure patients that, you know what, we see this all the time. You are not alone. Really helping that patient to feel normalized coming into that experience. Assuring them that, your therapist will talk you through everything. I can have the therapist give you a call if you want to talk to you before you come in. So just really assuring that patient that when you come in, we're going to give you an experience that's valuable for you, right? And then when they come in the clinic, you go into a lot of, and this is kind of going back to your question too about if I'm an outpatient ortho starting a pelvic health program, you think about a lot of clinics that you walk into, it's a busy, loud gym, and there's sports posters and, winning and things like that. Yeah. And so pelvic health, these patients a lot of them, they're super stressed, especially when you have pelvic pain. So when patients walk into your office, if it can feel kind of spa-like, cozy, inviting, if there's an ambiance of sort of calm and we're going to take care of you. So walking into that waiting room, it should feel, the lights should be not too bright. There should be like maybe some calm music or a noise machine. You don't want the Real Housewives, not to criticize any show, but you don't want it like a crazy show on TV, like reality TV or something. You don't want that on in the background. So kind of thinking about that too, just that whole experience of walking into the space and then going up to the front desk. And then, thinking too about wait times, you don't want to have to sit there. That's all of healthcare too, right? But when you're dealing with such a sensitive body part, now that you have more anxiety because you're sitting there waiting, wondering what's that person here for? Do they know what I'm here for?
Right. Yeah. Right.
And so just that whole experience should be, to me, so I always say that healing starts with the environment. So if patients walk into an environment that's calm and healing and feels safe to them, then that is going to lend to healing. And so that's from one angle of your question. Yeah. So then going to the angle of the question from, what does this look like for patients as far as, I'm treating a condition versus, there's more of that episodic care of, I'm coming in for this thing, I do X number of visits, I'm leaving, versus, is this something that should be introduced at certain points of life? I would love to see at some point in our lifetime that it becomes just normal that, okay, you've hit your teenage years, we should get you in to see a pelvic therapist and just have them do a screen on, are you having any problems using tampons? Are you, kind of starting some of those screening questions of, do you ever leak urine when you're playing sports? Just kind of starting that assessment of, do you have some pelvic health conditions that could turn into something bigger down the road? Because so many times we'll have patients come in and say, well, I ran cross country and we just thought it was normal to leak urine, right? Or I never could use tampons because it was always painful to try to put them in. And so if we could have sort of this standardized, you just go in, get a screening, and a lot of folks oh, you're good, you're healthy, great. And others, it might be oh, you have some things that we could work on or address, right? And then I think there's other time points too. So as you mentioned, prepartum. So can you come in and do some labor and birth prep? Can we do some work there? Postpartum, obviously, is a huge one. So just automatically, can you come in, get some help there? And then when you get to perimenopause and menopause, there's lots of changes as estrogen declines. It affects pelvic health. So are there some things that could be addressed there? So there probably are certain stages of life where it'd be great that, you know what, you go get a colonoscopy at 45. You know what, you're also going to go see a pelvic therapist and let's see, kind of how everything's working. So there might be times where that really should just be kind of this sort of part of the wellness in addition to those episodic, addressing those specific health conditions too. So I love that question so much.
Yeah, just following up on that, there was actually a report from APTA, and you might have, I think you're probably familiar with this report, that only 3% of symptomatic patients with incontinence are actually referred to a pelvic floor PT by a primary care physician, meaning there's a pretty big, underdiagnosis gap. How do you think we can bridge this using technology, using better education? I'm sure you spent a lot of time thinking about it. Want to hear from you as well.
Yeah. So that 3%, I mean, isn't that such a sad number? And some of that comes from the small percentage of patients who will even mention that they have it.
Yeah.
So they're going into the doctor. I think because something like urinary incontinence, it's just been so normalized. Like, oh, this is just part of being a woman, just part of having babies.
Yeah.
You know, it is what it is, right? And so I think some of it is, you know, if we can use technology to kind of get the word out that just because it's common doesn't mean that it's normal, if that makes sense. And so we also don't want to denormalize, right? So like you're abnormal because you're leaking. That's not the case. You're actually very normal. But you have a very common condition and there's actually something that we can do to address it. So I think a lot of people just don't know that that's an option. And then I think, you know, some of it too is, can we use technology to introduce ways for patients to kind of engage in their own screening where it kind of reduces that embarrassment and shame of, oh, I can use this, go on this website and go through these screening questions and maybe be sort of guided through this process of figuring out like, oh, I have something that therapy could help me with. Now I can get connected to a pelvic health physical therapist. Is that making sense? Yeah. Am I saying the right words?
Yeah.
No, absolutely.
If I'm not, y'all tell me, stop me, and be like, girl, let me correct you real fast.
No, I mean, it sounds honestly like a perfect use case for implementing AI into some of these systems. You know, you have this ambient listening in the background, listening to a patient narrate their symptoms. And you know, sometimes the patient themselves are not able to pick up that they might have any of these issues.
Exactly.
But, you know, an artificial intelligence, you know, ambient listening bot could. And then could, you know, suggest to the doctor, hey, like maybe a PV, you know, referral would be apt here.
That would be amazing.
And so, you know, one thing that you mentioned before, you know, you said, you know, just as people, you know, hit 40 or 50 and have to start doing routine colonoscopies. We have it for mammograms as well.
Yep.
You know, all of this is standard. You know, insurance encourages patients to do this.
Yeah.
Pelvic floor therapy is not at that same place, right? Like you're not hearing the same momentum around that.
Yeah.
Is pelvic floor therapy, and you know, this is a blunt question, but is it a nice to have or is it a need to have?
Well, I would say, of course, a need to have,
right.
but I'm a little biased.
Right. Like, what are the implications? See, if someone doesn't do routine colonoscopies, the implication is that they're at a significantly higher risk of having like pretty advanced, finding their cancer advanced. Same with mammograms, right? What is the risk of not doing pelvic floor therapy at the times when you should be doing it?
So, you know, just to kind of hone in on a specific diagnosis. So when you think about incontinence, you know, incontinence is the number one reason that people get admitted into nursing homes, right? Because of the burden of care for that loved one. And so when you think about if you could have backed up to their 20s when they had their first baby, and that's when their leakage started, and then their 40s, it got worse because estrogen declined and it affects the pelvic floor, muscles and tissues. And now you've turned into this, you know, person who is wearing diapers all the time, and it's become a caregiver burden to handle that. And so now you're going into a nursing home. And so when you think about that kind of an impact, it really is just really massive. To hone in on another diagnosis, you know, I think of all the patients that I've seen that they have pain with sex, you know, either after having a baby or maybe they've always had that. And you think about the impact on how does that affect future childbearing, reproduction? How does that affect decision-making around expanding your family? How does that impact your relationship? So I've had so many patients tell me this is impacting, you know, my relationship with my husband, my spouse, my partner. And so when you think about just kind of how huge that can be in this person's world, it's impacting every facet, even though it's just pain with sex, it's not just pain with sex. It's this huge, massive thing. So when you start looking at functions of the pelvic floor and bowel, bladder, pelvic health, pelvic pain, it's just so impactful on your entire life. Yeah.
Yeah. I mean, if you're saying that the number one reason that people go to nursing homes is because of incontinence.
Yes.
And pelvic floor therapy can have a tangible impact on that, then it really speaks to like this whole thing of like, this is an interconnected system.
Yes.
The burden of the taxpayers' dollars is really going to, housing and taking care of these patients who could have been helped earlier had they had a little bit more preventative thinking and, had their providers been a little bit more proactive when it comes to their pelvic floor. I think that's that's a pretty significant damage that's being done today, given that it's, pelvic floor is not, therapy is not as common as it should be.
Yeah. And then you look at the cost of pads and diapers and, it's a $1 billion industry, right? So can we put that money somewhere else that could make for better lives,
And maybe changing the topic a little bit when it comes to reimbursement, right? We've seen in the last couple years, we've seen rates cut across the board, right? And especially in therapy, it means you just have to see a lot more patients, right? Now, earlier you spoke about the fact that you want to create a relaxed environment. You want to make it so people feel like, hey, it's, they look forward to going there, which I 100% agree with, right? But those two facts can sometimes seem at odds, right? Where your goal isn't to just, see 50 patients a day. Your goal is to provide high quality service for every single patient.
Absolutely.
You see. How do you think about that dichotomy?
It's really challenging. And I think this is why we're seeing, I think we're going to continue to see a shift of a lot of the private pelvic therapy clinics shifting to a cash practice so that they can basically make enough money to make it worth running that business and to do it well, to do it the way that they want to. And then I think we're going to see insurance-based start to be more of your hospital-based clinics because they can sort of recoup that, so to speak, with the rest of their services and their other outpatient therapy services. So I really think that's the shift that we're sadly seeing occur right now, and I think it'll just continue.
What do you think is the hardest part right now about running your own practice? There's a lot. It's running a whole business basically with the technologies that exist. So what's the hardest part in your opinion?
Yeah. So are you thinking from like from a private practice standpoint or a private practice? Yeah. So I actually did own a private practice for 5 years and it's all hard. Right. It's all hard. But definitely, reimbursement was definitely one of the biggest challenges. I feel like documentation is one of the biggest challenges, especially when you're in a practice where you are seeing patients one-on-one. A lot of your visits with patient require a lot of your visits with patients require a lot of emotional energy because a lot of their stories are, you'll hear that from pelvic therapists over and over, like, oh, I'm so tired because I had 3 patients with chronic pelvic pain today and I'm whooped, and it's not because they don't love their patients and they don't appreciate hearing their stories, but it just takes a lot of energy. Right. So you think about, you get to the end of a 55 minute visit and you have that 5 minutes for documentation time and you're like, I kind of want to just sit down and breathe for a minute, right?
I know.
So I think that is a big piece that I saw with, especially my newer therapist. It was really hard for them to balance the, how do I get my documentation and those pieces done and see my patients and do high quality care. And of course, therapists are always going to choose the patient care. They're not going to choose the documentation and all that jazz. Trying to think if there's anything else that's a challenge. I think those are really the 2 biggest challenges.
Yeah. So just following up on that, I think you sit in a unique position as the president of the Academy of Pelvic Health. What are your big bets or your main goals that you're trying to accomplish by the end of your term, right? And maybe some predictions that you could even speak about. I think we'd be fascinated to hear from your perspective.
coming into this position, one of the main goals that I had was to further support the educational component that's within the Academy of Pelvic Health. So they develop and maintain and teach a lot of the courses for a baseline entry into the pelvic health world. And so I had been a part of that process, 10, 15 years ago of developing courses, and I'd kind of seen it evolve. And it was at a place where it just needed some additional infrastructure support. And so that was one of the things that I came in that I really wanted to support and be a part of, from my knowledge of having been a part of course creation, having taught courses with the Academy, taught courses with, I've also taught with Herman and Wallace. I still teach with them. I had been the director of education on the board of directors several years back. So I just had multiple experiences that coming into the presidency, that was kind of one of my big goals, was to help support just a further development of the infrastructure because the courses had grown so much. So those courses have just, we went from 10, 15 years ago, 10 courses a year to, I don't know how many we have, but it's way more than that.
Got it.
And so we've put in place an educational program manager. And so there's some things that have been done to kind of build an infrastructure that will just continue to support itself and outlive me, hopefully by many, many years, or at least create an infrastructure that we can build upon in another 10 or 15 years when there's more growth. So that has happened. It's in process. It's really exciting. So that was from the Academy side of things. That was, I don't know if that was a great answer or not, but.
No, it wasn't. And you built the CAP OB. Was that part of the Academy? Was that separate?
Yeah.
And what compelled you to do so?
Yeah, that was part of the Academy of Public Health. So I was one of the initial group of people that developed that course content. So that's the Certificate of Achievement in Pelvic and Pregnancy Physical Therapy. So we have the pregnancy side, and then we also have the pelvic physical therapy side. So there's kind of two different caps. So I was on the pregnancy side build. And, what really motivated me to do it was I always knew that I wanted to be a part of teaching and mentoring. And so I got invited to be a part of this group, and I jumped on it. Mm-hmm. So I was fresh out of the Duke residency, and I was all, somebody said, "Hey, do you want to join?" And I was like, "Yeah, sign me up. I'm there for it today." And so, and it was a really amazing experience, because when you're in this group of people developing a course on your own, you can kind of, swim in your own little cesspool of knowledge. And but when you're with a group of people and you're having these conversations of, well, I don't think that's what that research article meant. Are you sure? Right. And you have this back and forth of really just, it forces you to do a deeper dive into the content. Mm-hmm. And so it ended up being just an amazing opportunity that really grew me as a therapist. I learned so much in the process of developing courses, almost as much as I learned in the residency. Yeah.
I'm curious about, is there any interesting remote patient monitoring or like chronic management of these patients that you encourage other therapists to do outside of the four walls of the room?
So by the remote patient management, are you referring to the
just anything?
Okay,
really.
like telehealth?
Yeah,
or
any kind of telehealth, any like devices that you encourage people to use? Or?
Yeah, absolutely. So I will say in 2020, we definitely transitioned to doing some telehealth, which you would think is not a possibility with pelvic patients, but there's actually a lot of things that you can do remotely. So I would work with patients using vaginal trainers, for instance, kind of walk them through that process, or walk them through therapeutic exercises or other behavioral education. And I think a lot of practices have continued to keep some piece of that. Mm-hmm. Definitely not at the intensity of 2020, of course, mm-hmm. but I think some practices have continued to institute that for some patients, especially when you have people that have to drive an hour or 2 hours. So it's great when you can put some telehealth into those components. From the remote monitoring standpoint, I know that's something that's newer. Mm-hmm. And I'm not as familiar right now with how that's being used in pelvic health. Yeah.
Got it.
But there's definitely a lot of home devices as far as, like biofeedback units, things of that nature that patients can use at home.
Yeah. Just thinking, if it's clearly access is a problem, right?
Yeah.
A lot of the patients who need it are not able to get it. So maybe delivering it remotely, at scale.
Absolutely.
To get as many people access to someone like you who knows so much about this in the space, regardless of, whether they're near you or not.
Yeah, absolutely. I kind of had this dream, I would say 10 years ago, of like a choose your own adventure therapy of patients could, get onto some type of, which is kind of sounds like AI, get onto some website and say, I have this going, and it can prompt you in the different directions that you need to go based on what you're telling it.
Yeah.
So I definitely see that being something that could be potentially to scale, as you're saying, in the future.
That's exactly what we could be using AI to be doing.
Absolutely. Yes. Absolutely.
Yeah.
Mm-hmm.
What is your bold prediction when it comes to pelvic health or therapy in the next 5 years? Like, where is the space going? Like, where do you want it to go? Right? Like, what is, whether it's technology or not? What is your bold prediction?
Gonna chew on that one for just a second.
It's fine.
I'm just thinking about how I've seen therapy change over the last.
I'm sure you've seen eras of it.
Yeah, let's say I've been a therapist for 23 years. Yeah.
Same age as Hirsch?
Almost.
I'm kidding.
Just a couple years off.
I love it. I'm so old. Gosh, bold prediction. I'm just gonna talk out loud for a second.
Yeah.
I'm just thinking about how when, I hear stories of therapists in like the 80s and 90s. It was kind of the golden era of like people were getting reimbursed all these great rates, and there was some abuse of insurance happening in that time. And then, Medicare, Medicaid, they put the smack down.
Totally.
Use the word smack down. They put the smack down on reimbursement. And then you hit late 90s, early 2000s, and people were graduating PT school and couldn't get jobs because there were all these cuts. And so nobody was hiring. And then, so you kind of see these, I feel like these sort of ups and downs. And I think right now we've had so many reimbursement cuts, which is insane because inflation is not taking us in that direction. But yet these, therapists are graduating from school and expecting high pay because they have so much debt from PT school. I feel like the high cost of education and the continued restrictions on reimbursement and the lack of value in our healthcare system on something like physical therapy that it's one of those things that if it went away, it would be felt after the fact. It would be like, oh, shoot, we lost that, right? But I think the profession right now is really thriving. But if things keep going that direction, I think it's going to really change the landscape, because I think you're going to have fewer people who want to go to PT school because they're going to hear, oh, you're going to come out with so much debt and your ceiling for pay is here. And so I think it's going to change. I hate to use the word quality of applicant because that sounds terrible, but it's gonna change who's applying for physical therapy school, who's going to physical therapy school, who's graduating with those degrees.
Well, I also think about it. I mean, the cost of education is one of the fastest growing, along with healthcare, right? The cost of actually doing healthcare is two of the industries that have just grown so much. There has to be a point at which the school itself says we can't charge this much because you're just not getting the demand as well, right? And so, I'm curious to see how that goes. I want to move to a different segment, which is just about getting extra time in your day, I think. Have a couple questions there. I think the first one being just personally, right? And we kind of listed some of your interests earlier. We just pulled them from the website. But if you had an extra hour in your day every day, what would you spend it on?
In reality, catching up on laundry. If I were going to do something fun.
Yeah, something fun. Yeah.
I would do something like, well, on my bucket list, I want to learn how to play the drums.
Yeah.
I would do drumming lessons.
That's awesome.
Right? Yeah. So
That's cool.
That's awesome.
Yeah.
And sort of the reason we bring that up, right, is when you think about you owned a practice for 5 years.
Yeah.
And you think about dealing with insurance, dealing with documentation, dealing with all the admin tasks. It adds up, right? You see you see patients for 8 hours, 9 hours a day, and then you're doing the rest for 4 to 5 hours a day, and all of a sudden you're putting in 12 to 14 hours a day every single day.
Yep.
Right.
And the weekends. Don't forget the weekends.
And the weekends, yeah. By every day, yeah, definitely the weekends. How do you think the quality of life would have changed for you and your staff? And I'm sure you had some amazing team members that you worked with.
Yeah.
If you got those hours back.
It would change immensely, right? So to have some sort of AI generated situation where it's taking care of those authorizations and verifications and streamlining documentation, and it would be beautiful. Everybody would be happier. That was, as an employer, one of the I would do one-on-one meetings on a monthly basis with my therapist. And again, especially my newer therapist, the number one thing that came up, the number one content area that came up was, I'm struggling with getting my documentation done and I feel overwhelmed because I'm ending my patient day and I go home and I'm documenting for 2 to 3 hours on my couch. And that's just, so to change that to where that 2 to 3 hours was, exercising or cooking dinner or talking to a friend, hanging out with a friend or talking to your spouse, whatever that may be. I think that is where there is a lot of burnout for physical therapists, is that space of, I did all of my patient care and then I have to go home and still do this thing that I have to get done, or I'm letting it stockpile and then I'm stressed about it. And then I'm doing it on a Saturday. I'm going to the clinic and sitting at the clinic all Saturday trying to catch up. Yeah. So I think it would be a massive quality of life improver for sure.
Yeah, no, I think that I 100% agree with you. And on the burnout point, I just think that that's where recruiting and retaining talent, like that makes the difference, cost. Right?
Yeah.
And what we've seen is that if even when you're recruiting therapists, and maybe you saw the same as well, they ask a lot of those similar questions as well, right? Of like, what is my workload going to look like? What tools do you have to help, et cetera, right? And I think,
what are my productivity expectations?
Exactly.
Do I get documentation time? Do I get paid for documentation time? Yeah, those were very common questions.
And what does the performance bonusing look like? We've seen that as well. Some practices are really analytical. Some kind of have set pay. So we see that. We see that all the time.
Yeah.
Awesome. Well, anything else that you'd want to share, discuss or top of mind, or
this has all been so good. I don't know how good my answers were. I don't know.
It was great. It was great.
Good,
I feel like I learned a lot too. So
awesome.
I learned a lot. Is what I'll tell you. I definitely learned a lot.
When you get into pelvic health PT.
I learned a lot, which is great. I think which is fantastic.
I always say most therapists talk about backs, knees, and necks. Pelvic PTs talk about poop, pee, and sex.
Wow. Put that in the title.
I know. Needle point that.
Love it.
But, awesome. Thanks so much. We're very grateful for you.
Thank you so much.
For you and your time, and for the ability to come out here. We really do appreciate it.
Oh my gosh.
Thanks for
thanks for having me, and thanks for your interest in just talking about these very important topics, not just pelvic health PT, but just, physical therapy and all of these challenges in general.
Yeah.
Yeah.
Absolutely.
Yeah.
Awesome.